This PowerPoint is going to cover the GI assessment and studies. If you need a review of the A&P, or the anatomy and physiology of the GI system, please refer to the other PowerPoint that specifically covers that anatomy and physiology, just if you needed a review. So when it comes to the assessment of the GI system, we're going to start with talking with subjective data. You really want to explore the past history for the problems related to the GI function, whether that be abdominal pain. How long has that abdominal pain been there? What are the causes of that abdominal pain? Nausea and vomiting. Again, is there anything before or after that makes it better or worse? Diarrhea, how long have they been having it? The consistency. Constipation, abdominal distension, jaundice, anemia, heartburn, dyspepsia, that kind of indigestion feeling. Changes in appetite can be a big one. Maybe some bloody vomit, food intolerances or allergies, indigestion, excess gas, bloating, lactose intolerance, melena, that's where the black tarry feces due to blood in the GI tract come from, trouble swallowing, hemorrhoids, rectal bleeding. So you're really going to get a full history of that. You want to ask the history of like reflux, gastritis, hepatitis, colitis, gallstones, peptic ulcer, cancer, diverticula, hernias. All of that is going to give us a better picture of this patient. You really want to look at their past and current drug use, whether it be over-the-counter drugs, things like ibuprofen, Tylenol, recreational drugs, prescription drugs. Another big one is herbal products. Is there something that they're taking that is making their GI system worse? Vitamins, nutritional supplements, all of those are going to give us, again, a bigger picture of their GI system. And then ask about recent hospitalizations related to the GI system, as well as the abdominal or like rectal surgeries. This could include when was their last colonoscopy, things like that. So all of that is going to be good with the subjective part of the assessment. This is more of just an FYI. You don't need to memorize this, but it's a good picture of what kind of pain in the abdomen relates to what. So you want to ask about their health practice related to their GI system. Foreign travel is a big one. We'll talk about hepatitis in another section, or parasitic infection. Assess patients' habit directly related to their GI function, such as consumption of alcohol is a big one, and cigarette smoking. You want to know their nutritional metabolic pattern. Take a diet history, inquire about content of food consumed, amount of food consumed. Are they using sugar or salt substitutes? Caffeine intake. Welcome to nursing school. You're going to have a high caffeine intake. That might change your bowel habits. Fluid and fiber intake, and food allergies or intolerances. You want to note elimination patterns, whether the frequency, time of day, usual consistency of stools. So every person's bowel habit is a little bit different. Do they use laxatives and enemas? Do they have a chronic use of laxative and enemas? There's some populations out there, for example, some of the elderly, that they will be constipated, so they take an enema or a stool softener, and that gives them diarrhea. So, oh no, now I'm going to take anti-diarrhea medicine, and so they go back and forth between those two. But you really want to know how much they're using. You want to know their activity and exercise pattern. Are they of ambulatory status and ability to secure food? Note any limitations patients' ability to feed themselves, as well as their ability to access a toilet. So if they can't feed themselves, they might have a decreased input and decreased output. Their sleep and rest pattern. There is a big connection with sleep and rest connected to the GI system. That's why if you stay up studying for your next exam till 2 a.m. and all of a sudden you have diarrhea, it's related to your sleep. So you really want to know what is their ability to sleep. So then we get to the objective data. This is getting in there and looking at their abdomen. You really need to expose the abdomen for inspection. You want to provide privacy for a patient. Don't just walk in there, rip their shirt up. You want to say, hey, can I please assess your abdomen? I'm going to pull your shirt up. I really want to look first. So there is the specific order with the abdomen. First, you want to inspect the abdomen for skin changes, umbilicus, symmetry, contour, observable masses, and movement. Then the next thing you're going to do is you're going to auscultate. You're going to use the diaphragm of the stethoscope to auscultate the high-pitched vowel sounds and the bell for the low-pitched vowel sounds. You really want to use like present or absent vowel sounds, increased or decreased, or hyper or hypoactive vowel sounds. A lot of charting uses the word hyper and hypoactive vowel sounds. They say that you should really assess this for about a minute to really assess the vowel sounds. High-pitched tinkling, gurgling, or rushing. There could be stomach growling. Also, listen for vascular sounds. Normally, you should not hear what's called a bruit or an abdominal aortic bruit. That should not be heard when you're listening. Percussion usually is used to estimate the size of a liver and determine the presence of fluid, distension, and masses. Day-to-day use, most nurses do not use this, but it's a good skill to know. Tympany, usually high-pitched or hollow sounds. Dullness, fluid, or masses. Palpitation, you really want to be careful with palpitation. Don't just jump in there. If you see any kind of, when you're inspecting or you find any abnormalities, you really don't want to be pushing on the abdomen, because if they have masses or swelling, you don't want to make that worse. Light palpitation is used to detect tenderness, cutaneous hypersensitivity, muscular resistance, masses, and swelling. You really want to use smooth movements and palpate all 4 quadrants. Deep palpation is used to really find the abdominal organs and masses. One-handed palmar surfaces of fingers, two-handed fingers at the top of the hand, apply pressure on the bottom hand, which feels for the organ and masses. Really, you want to palpate all 4 quadrants again, noting the location, size, and shape of masses, as well as presence of tenderness. Again, this is a brief reminder of the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant, and what it looks like. Just remember, it's how they're facing. It's not when you look at their abdomen. It's not your right side. It's the patient's right side. And then the photo B here just kind of talks about the different sections. Now we get into the diagnostic studies of the GI system. Reminder that invasive procedure require consent. That is a big one. Any diagnostic tests that involve specific medications, such as sometimes they need an MRI and they need something for anxiety, a little bit of sedation, or any kind of solution such as contrast, verification should be made for allergies. This includes, especially for the contrast, shellfish, iodine, or any previous reaction to contrast solution. You really want to assess that prior to even taking them down for this kind of test. The nurses really prep the patient for the procedure. This really could include anything from a bowel prep, NPO status, and ensuring that the patient drinks a specific amount of contrast medium. For example, one of the studies, you have to drink the contrast medium and then you go down in 4 hours, and you have to remain NPO, and it really looks at how that contrast moves through the GI system. Also, the nurse is responsible for assessing the patient afterwards for complications from that procedure. This is a big patient safety. So this is some example of the radiological studies of the GI system. This is the upper GI series and a lower GI series. Usually a patient swallows, for the upper GI series, a contrast medium, a thick barium solution, also known as gastrografin. This really can look at esophageal strictures, polyps, tumors, hiatal hernias, foreign bodies, peptic ulcers, maybe even something like a bowel obstruction. Sometimes patients will throw up this contrast because they can't even tolerate because of the esophageal stricture, so that really tells us a lot of where the stricture is. A lower GI system is used with a barium enema. It really looks at the lower GI system by means of fluoroscopy, and the enema fills the colon, and you can see the contrast media. Really, it can detect polyps, tumors, and other lesions. One of the things you should really focus on when you're studying is the really the responsibilities of the nurse during each of these tests, whether it's pre or post or during. You're going to have to explain to the patient. Yes, the provider is usually the one who tells the patient what study they're getting done, but a lot of times the nurses come through and we really explain the before, the after, the procedure, really preparing that patient before they go down. It's important to know what labs to watch for after a diagnostic study. A great example of this is a prothrombin time, PT, before and after a liver biopsy. It is very important because we want to anticipate any bleeding and clotting issues. A reminder, you'll see this throughout, and I'm going to say it a couple of times. The liver is very vascular, so anytime you think liver biopsy, think bleeding. So one of the first diagnostic studies that they really will do is an X-ray. This can tell us kind of the external idea of what's going on in the patient. It doesn't go deep into the body, so you can't see things that you could see on a CT or MRI, but it's a great starting point that we could look at. The more invasive one is called an endoscopy. This is usually a direct visualization of a body structure through a lighted fiber optic instrument. They can go and look at structures, usually like the esophagus, the stomach, duodenum, and the beginning of the colon. This can be done at bedside in like critical care units with severe critical care patients, but it's usually done in an endoscopy unit or an OR. Another one that they can do in like endoscopy is a ERCP, endoscopic retrograde cholangiopancreatography. It's a long word. That's why everybody usually just calls it an ERCP. This is direct visualization of the pancreatic duct, the hepatic duct, and the common bile duct. So if there's any kind of gallstone issues, we'll talk about this more in the pancreatic system, they can do this ERCP. Camera is usually attached to the endoscope, which permits video and still pictures to be taken during the endoscope. So a lot of patients will get those pictures. And then they can also do biopsies. So forceps or cytology rushes can be passed through the scope to obtain analysis for tissue. So you can also do a lower GI scope, and this is usually called a colonoscopy. It has gone through the rectum and they look at the lower part of the body. This is one of the harder ones because you really have to prep the patient, where an upper scope, the patient can be NPO or clear liquids for a while. The lower scope has issues because there's lots of stool that can be blocking everything. So this is where you get people who are really colon prepped. The diagnostic studies, they can look for things within the actual ascending colon, descending colon, the cecum, things like that they can really go and look for. Another diagnostic test is called a video capsule endoscopy, or a VCE. It's a pill-sized video camera that the patient actually swallows, and then the patient actually wears the electrodes on the outside of their body that sends a message to a box, and then the box can really look at the scope. This is a non-invasive way to do a scope. Really, they usually start with a patency capsule first, so they're going to make sure that the patient can pass that video scope. Nothing worse than leaving that video scope in there. So they'll first try the patency capsule and then they'll do the video. This is non-emergent. This is for somebody that needs some basic colonoscopy look, and sometimes it's not a great visualization, so they'll have to go in and do a scope anyway. So the liver biopsy, the purpose is really to obtain hepatic tissue to reach diagnosis or to assess for fibrosis. Really can be used for really assessing the progress of liver disease, including things that really happen with some of our alcoholic patients or different patients, such as chronic hepatitis. This could be an open biopsy or a closed or needle biopsy. Most of the time it is a closed or needle biopsy. Really, you want to look for risk of bleeding due to liver vascularization system. There is so much blood shunted into the liver that bleeding is an issue. And as we'll talk about when we talk about hepatitis and alcoholism, they already have issues with their PT and INR and their clotting factors. So they are at risk for bleeding. Clotting factors should be evaluated before the procedure. PT and INR really need to be reviewed. Sometimes those are reviewed and those are like, it's made a decision of this is a higher risk for this patient to bleed that we don't even want to do the biopsy. After the procedure, the patient should be placed on their right side, putting pressure after the procedure for at least 2 hours, sometimes longer.